sports-related injuries are on the rise.
Again, into that second most common category of the overuse.
Tonight on Call, we run down the facts for prevention.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
And which was healthier, the yogurt and the bagel?
Alright, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Blow hard! Blow, blow, blow! Keep pushing!
And try to take just your head.
Pull red handle to open bag.
This week I attended a presentation by soccer coach Luma Muffla, who is highlighted in a book entitled Outcasts United, about teaching and coaching soccer to refugee children in Clarkston, Georgia. She spoke about how sports taught these desperate kids teamwork and the value of conditioning, and gave real-life examples of it. Indeed, organized and spontaneous sports have a great value to our society. Some 38 million children and adolescents participate in organized sports in the U.S. every year. And although it teaches principles for a living, there are risks of injury that come with that endeavor. Injuries to feet, knees, elbows, hips, heads, and the moving parts within happen in a significant percentage of these youthful athletes. And of course there are scrapes and bruises and cuts to the skin that surround and protect our sporting youth. To help us better understand the causes, the treatment, and most important, the prevention of such injuries, we have brought to you experts in this field. Dr. Judith Peterson of SoDak Rehab in Sioux Falls is board certified in sports medicine and in physical medicine and rehabilitation. Dr. Erik Peterson, no relation, of Core Orthopedics Avera Medical Group, Sioux Falls, is a board certified orthopedist with a special subspecialty in sports medicine. An additional claim is that he's also certified by the American Board of Family Medicine, which is quite interesting, Erik. This presentation comes to you pre-recorded, and so unfortunately we are unable to take your live questions this week. Please realize this happens rarely, and remember to call in next time. Well, let's talk about who you are. Judith, I'm going to start with you. So what is a physical medicine and rehab doctor?
Physical medicine and rehab doctors think about how people function. And in sports, obviously the athlete really is thinking about functioning at their maximum potential. So the fields of physical medicine and rehab and sports medicine really align beautifully to help the athlete, create their best athletic performance on the field.
And you got into this, what brought you into rehab medicine? Was there something that stimulated your interest, or what was it, Judith?
Well, I think that when I was in training, it was so dramatic to me, the kind of advances that people could get through exercise, through interventions that were not necessarily surgically based or based on pharmaceuticals, but based on them correctly identifying exercises, carrying through with those exercises, and how you could create great outcomes with physical modalities, which is the physical part of physical medicine and rehab.
And so, of course, I know that you were the team doctor for the Philadelphia, or at least the Pennsylvania Ballet.
Correct.
Those were the people that were highlighted in the Black Swan, the movie.
Correct.
And but you moved to South Dakota, and now you're the team doctor for the Roller Dolls.
Yes.
Kind of a similar kind of a group of women, or maybe a little different?
Well, you know, it is philosophically the same, because you have people who are really trying to do extraordinary things in an environment. Now, ballet, of course, is aesthetics, and roller derby is athletics. But I think about it as people really achieving optimal potential and hopefully doing it in as healthy a way as possible.
Well, and I know that everything that the Roller Dolls raise, it all goes to charity. I mean, it's a wonderful group of women, and thank you for being part of that.
Oh, we are so lucky to have them here in South Dakota, because these are really good community citizens, and they truly give back to our community here in South Dakota.
That's
so
great.
Go Dolls.
Go Dolls. And Erik, you're a core orthopedic doctor.
Yes.
That's the orthopedic group in with Avera.
Yes.
And you've been here how long?
3.5 years back in the state of South Dakota.
And you were from where?
Yeah, I grew up just outside of Sioux Falls in Brandon, and attended school in college and medical school in South Dakota, and then went off to do my orthopedic training at the Mayo Clinic. I then spent an extra year after that doing arthroscopic surgery and sports medicine training down in Phoenix, Arizona. After that, I came back here to start my practice.
Came back to South Dakota.
Yep.
You said Arizona, too hot, terrible weather.
Too hot, yeah.
That was
yeah. The promise of coming
No
back was
snow.
that we've got to visit frequently.
So now, did you have family medicine experience, or tell me about that part of your?
Well, actually, I think that is just something I've looked at that on the Avera website, and it's inaccurate.
It's inaccurate. Okay.
I just can't get him to take it off.
So you're not a family physician
No.
first.
No.
You're an orthopedist first.
Yes.
And with a subspecialty and a Mayo Clinic trained guy.
Yes.
Yep. So, and what is your most common thing that you do? What is your burden of your experience?
My practice, I've got a pretty broad practice. I do a lot of general orthopedic surgery, so everything from fracture care to total joint replacement, and then the sports medicine part of my practice, which is both treating sports injuries, both non-operatively and surgically, and then also trying to work at the prevention side of injuries too.
Right. Yeah. Well, it may be that our audience is older. I mean, I think we have some young people in this audience, but I think our audience may be a large older group too, and it may well be that many of them were athletes. Now, the question that I would have of both of you is that are people who were in their 60s or older and were big athletes at one time, are they at higher risk of having arthritis and problems because they played sports or not?
Well, I think that's a very interesting question, because it raises the obvious question of, is it safer to simply sit in your rocking chair from the time you're 20 to the time you're 70? And if we think about that, the answer is that that's probably not a good idea, because what important muscle are you not exercising then? And the answer is not your brain, it's your heart that you're not exercising then. So that's not a good thing to do. So I think that overall, sports involvement can be tremendously healthy for people.
Yeah, I think so overall. I think the people that are, and I think the people who've stayed physically active their whole life really just do better in every regard. It's the ones that quit when they get done with high school or done with college, though, I think, that set themselves up for problems.
Yeah.
Same question.
I was actually interested in this topic when I was in residency, and I gave a talk on this when I was doing a sports medicine rotation down at the Mayo Clinic in Jacksonville, Florida, where I trained for one summer of my residency. And what I found, that I think the best series, there's actually a series of papers by the same group, and they followed a large runners group from California, and they followed them for about 15 years with radiographs at various intervals, and they recorded the age of the runners and the amount of mileage that they put on. And as they followed these people over the course of a decade and a half, what they found was that, in fact, these runners, who are actually fairly high, moderate to high mileage runners, probably an average of 25 to 30 miles a week, were not developing arthritis more frequently than a control population. I think the gist of it, from my experience looking at this and from other papers and just experiences out there, I think that exercise and activity in general does not predispose you to arthritis unless you have some sort of malalignment, which means, if you consider the analogy, I use this all the time, the analogy of your wheel and tire on your car. Now, your tire may be an 80,000 mile Michelin, but if you get a brand new set and the wheels on your car are malaligned, your tires are going to wear out and wear out unevenly before you get to that point in time. And I think that the same holds true for the human body. If our alignment is normal, our knee is stable, the ligaments are intact and functioning properly, that we're likely not at any increased risk. So that's the message that I try and convey to my patients also.
I'll make one last comment and then we'll go to this next thing. But I tell my patients this a lot. They come in and they're very elderly, or maybe even not so very elderly, and they've got arthritis because whatever reason. They've got osteoarthritis. And I say to them, there's studies that show that if you take that worst knee, bone on bone, they did a whole group of people with that the terrible arthritis, and they did half of them, they pushed them to exercise, and they left them on the couch. And after a good long period of time, they found that the exercisers did better, they had less arthritis, they felt better, they were stronger, they had less pain, everything worked. Would you agree?
I think that, it's important when you have arthritis not to let yourself get generally weak, because deconditioning can be its own separate problem. And I think you hit the nail on the head with that you have to pay attention to people as people, that people are more than just an arthritic hip joint. And we have to really focus on optimum health for our patients, which is getting them into an exercise program that they can tolerate, enjoy, and helps them get more healthy.
Great. Well, sports injuries don't just happen to professional athletes. Any one of us can be a victim as we go about our everyday lives. Brock Teske was just playing basketball with friends when he sustained an injury that could have affected his ability even to interact with his children. Here is his story.
Prior to my injury, I was pretty sporadic in my exercising. It was maybe once or twice a year, and so I was trying to get back into shape. And it was like the 6th week of exercising every week, playing pickup basketball, and I just planted and tore my ACL. Yeah, I was just driving the basketball, and I just kind of did a little hop step to plant and pivot to the right, and it kind of gave. It didn't completely buckle my knee, but it kind of gave out, and then I hopped off to the sidelines and knew something wasn't right. It just didn't feel right. Like right after it happened, I tried to walk it off and get back out there playing, but after like 5 minutes, it was pretty apparent that it wasn't going to be an immediate recovery. And I just went home, and I didn't really ice it or nothing. I just slept on it to see how I'd feel the next day. And that night was kind of hard sleeping. It was fairly painful. But by the next morning, the swelling had gone down, and it really didn't hurt much to walk on it. And after about 3 days of doing nothing, just regular walking, the pain was gone. It would get sore if I would extend it fully or bend it fully. But other than that, just walking around, I didn't really notice. It was just when I was fully flexed that it would hurt. I had a lot of apprehension before the surgery. There was an option given to me whether I didn't have to have it. I could have, lived a normal life without any type of activities. But the doctor told me that I'd have to wear a knee brace just to go outside and play with the kids in the yard. And it wasn't really, that was not an option. So I went with the surgery, and I was pretty apprehensive. And I don't know, it's been a really as positive an experience as I can imagine it could be. Now, since I've been injured, I either run or do exercises 5 days a week. So I've increased my activity level a lot because of this injury. If I'm not concerned about getting physically active, like athletic again, I could be done with my therapy. So it would be, I would say probably about 3 months of recovery before I would be back to where I was. But like I said, I got 2 kids. I'd like to get a little more physical active So they'll be getting bigger and be wanting to play outside and stuff.
And Judith was saying those two kids play for the NBA, so he's got to really be working on it.
It's got to be good.
But we really do wonder what an ACL is. I mean, he's talking about an injury to his knee. Now, this is a common injury, probably the most common, and probably the most debilitating potentially. And it's happening in young soccer player women, right?
Oh, yeah. Well, it happens in any sport where you have to make a cut or a twisting movement or a jumping movement. So if you think about it, you know, you're a basketball player, you're a volleyball player, you're a soccer player, those are your players that are going to be at risk.
You plant your leg, you turn, and your leg doesn't turn with you. Is that how that goes?
Or you land wrong, you know, from a jump.
In football, somebody comes from behind and pushes that back forward. I mean, so if you've got, this is your knee, is it that the top goes forward, or is it the top that goes, the bottom goes forward?
The latter there.
So the bottom is pushed forward. Somebody hits you from behind.
So the ACL resists that forward translation of your tibia or your shin bone.
Right. So your shin bone is held intact and doesn't move forward.
Absolutely.
Because of the anterior cruciate ligament, the ACL.
And it's most commonly a deceleration type injury, or you're changing momentum going from one position to the other. And we're talking, you know, a little bit football. I think it brings up a good point. There's two different types of ACL injuries in general. The most dramatic kind that we see come from contact sports like football and rugby, and those are the types that there's all sorts of just very dramatic videos out there that make people cringe. The more common, probably 80% of ACL injuries are actually the non-contact ACL injuries. And I think these are the ones that happen less commonly in football, but more commonly in sports like basketball, volleyball, and soccer. And I think the younger athletes are more particularly at risk for, especially the young women.
So young women, because they just don't have a developed ACL, or they don't have the muscles around it to support it? Or?
Well, you know, there's a lot of controversy as to why women are at higher risk. And it's been thought that maybe it's a difference in the anatomy in women. People have looked at hormone levels in women. People have looked at many, many different factors. But one thing that does seem to come up is that people who land with too stiff a leg, people who land with their hip too far toward the midline, tend to be at higher risk.
Hip toward the midline.
Kind of the knee kind of pointing more toward the midline than the knee pointing out away.
Okay.
That person who lands like that from a jump can be at much higher risk, and women can potentially land with that knee kind of collapsed inward in that way. And actually, if you think about it carefully, if as Dr. Erik Peterson said very correctly, the majority of these injuries are non-contact, nobody's slammed into you and you get this injury, gosh, doesn't that seem like there might be a really good opportunity to have a program that could be taught to these athletes to prevent these injuries? So a lot of people have been thinking about this.
All right, and let me just kind of summarize that in my own mind. Once again, you're better off with a bent knee than a straight knee.
Mm-hmm. Yeah.
So running with a bent knee, I think, is a great idea, because you come down on a cushion, and your muscles cushion and everything moves nice. Straight knee, you're jarring everything.
But in sports medicine, we call it the position of no return, and the best way to think about that is somebody who's very knock-kneed. So their knees and their hips close together, their feet apart, kind of the opposite of a bow-legged, somebody very knock-kneed. And if you watch some videos of how young women tend to land more so than the younger boys, they tend to land more knock-kneed and with straighter knees, and that puts the ACL at risk. And in getting back to the subject about girls, they tend to be, in general, more knock-kneed than boys, and that's what puts them. And they tend to get into that position no return.
So we're set up with this question, obviously. How do you prevent this? I mean, of course, you want to teach them to come down on a bent knee. I mean, that's part of it. I'm sure there's other things too.
Well, there's many factors that are involved with it. I mean, basically, what you want is you want people to land in a position where the ACL, which is that rope that holds that top thigh bone together to the lower leg bone is not put under so much stress that that rope will snap. Because when we think of the ligaments, they are like ropes. They're ropes that get put under tension with these jumps and with these movements. So you're absolutely correct. And a lot of different people have thought very carefully and have created several different programs to try to prevent these injuries. And actually, these programs seem to have a very good success record. And there's even long-term follow-up with these programs, and the programs have been very successfully implemented in various states. Bert Mandelbaum is an orthopedic surgeon who's based out of Santa Monica, I believe, and Bert Mandelbaum's group created the Prevent Injury Enhanced Performance Program, and that is a simple series of exercises that athletes, the student athletes, do at the time of the practices, and these really significantly decrease the injury rates because the kids are taught balance, how to land correctly from the jump, just as you discussed.
Bent knee.
And right, and stable, not the leaning off to one side.
Yeah.
Correct.
Yeah.
Exactly.
Knees
right.
shoulder width apart with some flexion.
With some flexion and spread a little.
Yeah.
Correct.
Yeah. Girls tend to put their legs together and they come down.
Yeah.
So if one would want to learn more about that exercise, let's say you're a coach out there and you want to teach your kids that you're coaching to prevent this injury, they could go online and Google.
Absolutely. They could go online and they could Google Bert Mandelbaum's program, which is, I believe, at aclprevent.com.
Okay, or ACL Prevent. I mean, search the
right, just search that.
Yeah.
And actually, Vision 2020 is a program that's organized out of Drexel College of Medicine.
That's where?
Which is in Philadelphia.
Vision 2020 out of Philadelphia, okay.
Right.
What's that?
And what that is something that's specific now to South Dakota, because Vision 2020 is trying to look at equality for women across a broad range of different social issues. But in South Dakota, the specific project is to decrease the rate of anterior cruciate ligament injuries of the knee in women, but of course we also want to decrease those injury rates in boys and men. And so the program in South Dakota is to try to get the message out about the fact that these are preventable injuries, and we would like people to learn more about exercises that can help stop this trauma.
Right. Any simple exercise that we could tell somebody to do right now? Erik?
I think hamstring strengthening is something, and there's many videos that you can find on YouTube that show you how to strengthen your hamstrings.
Which are which muscles?
The muscles in the back of the thigh and the ones that pull the knee back into flexion. They're your secondary stabilizer. So for people who don't have an ACL, your ACL is your primary stabilizer, or I like to describe it as it's the seat belt for the knee. If you don't have a seat belt for your knee, or you're at risk of the seat belt not functioning properly, or an injury to the knee, you need to have good airbags, secondary stabilizers.
Right.
So you need to have hamstrings. The hamstrings, if the ACL resists forward translation of the tibia, the hamstrings rein it back in and pull it back in. And young women tend to have a more quadricep dominant knee, meaning
the front
part of the thigh muscles are pulling the tibia forward. So they have quicker reacting, stronger functioning quads versus hamstrings, and that's one of the theories, the neuromuscular theory, to why some of these young women are at increased risk for tearing their ACL.
The muscles to straighten the leg are stronger than the muscles to bend it.
It's an imbalance.
Yeah. An imbalance. So the hamstring strengthener would be anything that would pull things backwards.
Bending the knee.
Yeah, bending the knee.
And it wouldn't be deep knee bends. That would be the quads. It would be what?
One of the easiest ways is it involves being in the gym and being on there's certain machines in a gym that every gym has that are meant to strengthen hamstrings.
It says hamstrings, and basically it's pulling back, bending, pulling it back rather than straightening it.
Yeah, exactly.
Right.
And deep knee bends can be very stressful on the kneecap.
Right.
And plenty of people have kneecap pain, but also known as patellofemoral pain syndrome, which is a long series of words that translates to kneecap pain.
Oh, say that. What is it again?
Patellofemoral pain syndrome.
Oh yeah, that's
better known as kneecap pain if you have it. So we don't want to create additional problems for people, obviously.
Yeah. I think another resource is the Avera Sports Institute in Sioux Falls has a program through their acceleration program, trains the young athletes also in how to land correctly. Also, we're working right now with Avera and Core Orthopedics in the sports medicine department to create ACL injury prevention program that we're going to both institute and train young athletes through the Sports Institute and also take to the schools to start helping these young athletes and trying to prevent the injuries. And the beauty of it is there's excellent level 1 data, which means that it's the highest level of evidence that we can get in the medical community that says that these programs work. They've already been studied in large groups of people, and you can go in and simply institute them with little, essentially no risk, little cost, and you can cut down on these non-contact ACL injuries by 75%, which is phenomenal.
Huge.
Right. And the ACL injuries are so prevalent that, in all seriousness, this year it's been profiled in national press, multiple national press, because these are just very, very significant injuries. And once you have an ACL injury, it may put you at risk to have arthritis in your knee down the road. So, we were talking about this on the way over also tonight, about how wonderful it would be and what a good thing it would be for society generally to do this intervention to prevent these injuries.
Right. Wow. Well, and we're going to emphasize that again in the end, because if there's a take-home message, this is going to be it, is to strengthen and land on a bent knee, not a straight knee. Run with a bent knee. Let's bend the knees more. The straight knee is a position of, what did you call it?
The position of no return.
The position of no return. Bad. Okay. Well, there are a number of treatments available when you have a sports injury. However, a better option is not to sustain one in the first place. Early treatment of symptoms and prevention are important to keep you in the game.
When we're talking about injuries, a lot of our sports can go into what we would call chronic injuries and acute injuries. And it's more your contact sports that you have more of your acute type injuries, like your broken bones, your muscle strains, your tendon ruptures, your cartilage damage, things like that. And then you have events and sports like swimming, where you get more of your chronic stuff, where you get a tendonitis of a muscle or of a tendon. You get like an impingement syndrome in your shoulder, things like that. So those are the kind of two very generalistic injuries that we see. And then you can whittle it down to, like you said, like muscle strains, which has to deal with your muscle pulling apart a little bit. You get your MCL sprains, which is all ligament type damage. And then you have, again, your broken bones. There's definitely a lot of things you can do, preventative measures. That's basically half our job, is to make sure that we're doing that, whether it's prophylactically doing ankle taping so we don't have an ankle sprain, or making sure that athletes are properly hydrated so we don't have something that could lead to a muscle cramping and then develop into a muscle strain, stretching and flexibility programs. And we work really close with the strength and conditioning staff to make sure that we're working together to have the athlete at their peak optimum performance level, so that they can try to stay away from all those little nagging injuries that you don't need. If it's an acute injury, if it's something that's new that you haven't felt before, it just popped up, whether it was on the weekend or whenever you were doing it, you can always do ice. Ice and elevation and compression, especially if there's swelling in there. Once you start, healing a little bit from that injury, if you're going to feel like you can get back to doing activity, then you can proceed to heat. And then make sure you ice after the activity is over, because with any kind of injury, you're always going to get a little bit of swelling at the end of it, a little bit of discomfort. And ice will take care of some of that.
Well, there's 3 pillars that an athlete needs to look for, all right? And the 3 pillars break down into, number 1, inflammation. Now, inflammation is your body's way of trying to heal, and sometimes a little inflammation, it's normal. But inflammation can also cause swelling. If you have any swelling in any joint, you should see your physician. Swelling is your body's way of immobilizing the joint. So if you're having that occur, something's going on there wrong, you should see a physician. The second pillar is loss of function. If you're trying to do a sport or an activity and you're having to change how you swing the golf club because your shoulder doesn't feel right, you should see a physician and you should get help immediately, because by changing your mechanics you can create other problems. And the third pillar is pain. While it's normal as an athlete gets older, you can have a little pain, discomfort, or maybe as a younger athlete you had a hard workout. That pain shouldn't last more than 2 days. If you have persistent pain, 5 to 7 days, you should seek a healthcare professional's opinion immediately.
So if you went to a university specifically to treat ACLs, would that be ACLU or probably not?
Yeah, no,
Bad
absolutely.
Absolutely.
No,
So,
absolutely.
well, we have talked about ACLU. Joke. That one of our.
It's essentially a lawyer joke, isn't it?
That is a lawyer joke, isn't it? So the question, anything else? We did talk about this man had an injury, and then we did talk about how to treat an injury acutely, and we learned about methods of acute treatment. Erik, come to us about it. I'm playing in a soccer field. Now my leg hurts. What should I do?
I think one of the key distinctions is a big red flag is there swelling in the knee. Bad things make the knee swell. If you feel or hear a pop, there's a 75% chance that you've either torn your meniscus or torn your ACL. So that's another big red flag. And then pain that makes you stop playing and not finish the game versus pain you can play through. And I think that's a big distinction. Is people are asking, well, how do I know if I need to seek medical treatment? Should I go to the ER? Should I call my family doc on Monday and try and get an appointment? Do I need to see an orthopedic surgeon? And I think some of those red flags that we discussed are indicators, or pain that makes you not able to do what you were doing is probably pain that should be evaluated. Pain that you can play through and is mild discomfort, you can treat with the simple things like the trainers and therapists said: ice, compression, rest, elevation, and try and give it a week or two of that. If it's not any better, seek medical treatment.
Right. The same way with a twisted ankle. I mean, the common story about a twisted ankle is ice, right? ICE.
Ice.
Yeah.
Put ice on it, compression on it, elevation on it, and that run of and then there are ankle stirrups you can put on if it isn't fractured, and then rehabilitation if it's lasting more than a couple of days. That's my standard.
Well, I mean, when people have swelling, people say, oh, my knee was swollen, and every time I took a step, I got much more swelling, and I just thought I would just keep waiting, and I was putting heat on it. You really don't want to be doing that. You want to get the swelling to go down, and so when people can ice consistently, they do themselves an enormous favor. Because if you use the ice correctly, you don't want to use ice necessarily on bare skin. You want to be careful that you're not causing yourself skin burns with the ice. But using ice consistently can be very, very helpful for decreasing swelling.
But that's acutely. I mean,
yes.
After a couple, 3 days, now we want it to heal. And so I've commonly said, okay, I'm done with that acute, prevent the swelling. Now I'm going to put heat on it to increase the healing. Is that a general good rule of thumb?
It depends. It depends. It's like everything else in medicine. It depends. It depends.
It's not as simple as a rule like that.
But I think if people are having joint swelling, I tend to stay with ice for a lot of those people.
Yeah. Erik?
I think in the acute phase, I'm big on the ice. When the swelling is down, and maybe when you get more a couple weeks out from it, or if it's not an acute traumatic injury, it's more of an overuse injury. Yeah. I think ice before, heat after, or just heat can have more of a treatment. I tend to tell people, as long as it isn't an acutely injured, swollen knee, ankle, wrist, shoulder, etc., that in general, do whatever feels good for the joint. And a lot of times people will say that for the overuse injuries, that heat makes them feel better.
I've heard ice for spasm, heat for healing. What do you think of that comment?
Oh, I like that. I like that.
I like that. Ice for spasm. People have low back pain and commonly ask me, ice for spasm, if you think it's a spasm problem. Well, I'd like to go the next step. So we've done this, okay, I've tried to go and play, and even though I'm the stoic South Dakota guy, I just can't play on that knee.
Yeah.
And it's swollen. So I go into the emergency room and they say, well, yeah, we've got an appointment for you to come in and see Erik Peterson. So Erik Peterson examines the patient. What are you going to do now? 3 days later, you think it's an ACL.
If the knee is obviously swollen, that's a big red flag for me. For a lot, first and foremost, so you can get a lot just from the history. Like I said, 75% positive predictive value for that history that somebody describes hearing or feeling a pop. So I think just sitting down and just listening to your patients, we can tell a lot. We live in an age of MRIs and other tests, and we tend to be very test heavy. And I was trained by a lot of older individuals, wise old birds in medicine that practiced orthopedics before there were MRIs and even CT scans, and that was in the era where you had to sit down and you listen to your patients and examine them, and you can figure out a lot, just like all other areas in medicine, taking a good history and exam.
And before you say any more, I would say you're a very young man, and you're saying these very wise words that I just have not been hearing from the young doctors as much as I would like. There's an article in the Annals of Internal Medicine by the guy who wrote the book Cutting for Stone, and two other people. You got to read this, Judith. And it's a beautiful story about the value of the physical exam and taking history, just as you said. Okay, I'm sorry. Go on.
I think it's right along those lines. There's too many people that practice medicine, and particularly orthopedics, based on X-ray and MRI reports. And I think that's just a big disservice. I think if all you do is look at the MRI report or the X-ray report, you're going to be doing surgeries that don't need to be done, and you're going to actually also miss a lot of people who need something to be done, but you've kind of glossed right over them because the radiologist who's reading that doesn't have the ability to sit down and take their history and examine them
and hear the story of the pop, and examine and see the.
I always tell people I treat the X-rays, the MRIs show this, but first and foremost I treat people and not X-rays, and the X-rays tell me maybe what's going on and what you would do if you were going to do something, but really the patient is who tells me what's the appropriate thing to do in the discussion.
And the patient, because the patient has pain in the low back, for example, you have to make sure that this is not referred pain. Because, as you know, you can have back pain for a variety of reasons, including pancreatic reasons, and you certainly don't want to be doing spine surgery because of a pancreatic issue. So you absolutely have to make sure that things correlate.
It's the history and the physical exam. It's a history almost bigger than anything.
But
so you see this patient in your office, and
so if they have swelling, that's a big red flag. Swelling with or without instability, if they've got a swollen knee.
Do you put a needle in to see if there's blood?
It depends. If it's very swollen, if the kneecap is sort of floating in the sea of the swelling, and you can actually test that to see if I call it a ballatable patella. If it's floating and you can actually push it down and feel that kneecap go down and hit bone and then float back up, I usually will aspirate the knee because there's usually blood in the knee, and that makes the patient a lot more comfortable. A swollen knee like that is always going to get an MRI because there's a high probability of either an ACL tear, a meniscus tear, or even a fracture of the knee that's allowing a lot of the blood to come in. So a swollen knee, I can also, we were talking before about the tibia or the shin bone coming forward. There's a simple clinical test that you can do called the Lockman maneuver or anterior drawer to test for that. And if somebody has instability, they're also going to get an MRI scan to do.
And we're going to need to talk about what you would do. Can you do it by scope, and what do you do to replace it? But we need to move forward. We're going to run out of time. This is too good. We're just running. So let's take this. With all the activities that our kids are involved with today, they are receiving more sports-related injuries than ever. Proper and early treatment is crucial during this formative time of their lives. Chuck McCullough of the Avera Medical Group Brookings visited with us about this issue.
What we're seeing now with the proliferation of children, young athlete sports, is this: a child who maybe is in gymnastics or in soccer or basketball, but they play that for hours per week. And we're seeing more kids performing more sports more frequently. This has been addressed by Little League Association to help prevent Little League elbow. For example, they'll limit the number of hours or limit the number of innings pitched. Now, other sports haven't adopted those things. We are seeing sports-related injuries again into that second most common category of the overuse. Maybe the young kid who's starting off August football two-a-day practices but has not prepared themselves for two-a-day practices. They start right away, they're out of shape, more likely to get hurt in that situation. Prevention is the key. And with a younger athlete, variety is important. As the body's developing, it needs strengthening and conditioning and running and playing different sports and a variety of activities as their body develops. Young or old, you need to be well-rounded. There are skills that will translate into other sports. I mean, you look at football players, they still lift weights during the season. They don't just play football. They lift weights, they condition, even during the season. If you look at runners, they're still running, they're working on flexibility, strengthening as they get older to continue to run. So a well-rounded program is essential to help prevent injury. If a person has a stress fracture in their foot, they can be doing some core work and some upper body strengthening. Rest is relative to the situation, the injury. So taking time off, maybe taking time off from throwing a baseball, and they could still be working on some core strengthening and some upper body conditioning. The hardest thing that I see is an athlete's identity is maybe based on I'm a runner, or I play softball, or I'm a swimmer. And when they can't do that particular activity, it affects how they view themselves. Maybe they have to deal with depression. Maybe they need to deal with issues related to that. Maybe their running was an outlet to deal with their work stress. Well, when you can't have that outlet, or maybe that you have that loss, it changes how you view yourself.
Important issues. Well, we're into this ACL tear, and I think the first question is, why is it bad, Judith?
Well, it's bad because the ACL is one of the 4 major ligaments that stabilize your knee. The ligaments being, of course, those ropes that are tying the bones of your legs together.
Anterior cruciate, posterior cruciate,
right.
Moving it front and back.
Exactly.
And then the lateral and medial
the side.
collateral, the
right,
side.
Exactly.
Keeping from moving.
The ropes that are keeping your leg from sliding all over. Well, what does it mean when your leg slides all over? It means that your leg feels and is somewhat unstable. And the reason that that is just not a good thing is because if bones are unstable, they can kind of bang into each other, and the bones can wear down and become arthritic. And arthritic bones can become painful and can limit you in your daily activities, vacuuming, as well as playing your football or basketball, volleyball, etc. So this is not a good injury to have.
Or walking down the street when you're a grandpa with your grandchild and having trouble and ending up with a total knee.
Which we'd say as leading to the early onset of arthritis, which was not ever what we would want.
Right. So the question I would have is this case that you're examining, maybe you put the needle in and you saw how much fluid, you relieved the pressure with the needle, and took some of that fluid out. When do you take them to surgery?
You know, I think that that has got a lot to do with the age of the patient and their activity level first and foremost. So somebody young and active, somebody who wants to participate in sports, if we get the MRI, and the MRI shows that they've just got a torn ACL.
And these generally just tore completely. I mean,
yes.
They're just...
Yep. Yeah, sometimes you can get a sprain in them, and those can go back to being normal unless they stretch out too far. But usually, it's either a mild sprain or it's a complete tear. The complete tears don't heal. The ligament is inside the knee joint, and it's bathed in the fluid of the knee joint, and that probably prevents healing. The factor that prevents most the healing of the ACL. So the ACL will not heal like some other ligaments in the knee that are outside of the knee joint and not in that joint fluid, synovial fluid milieu or soup, so to speak. So if I've got a patient who has just an ACL tear, that I think is Brock, the gentleman who gave his personal story. It's interesting. You listen to his story. He said even the next day he started feeling better and the swelling was going down. Probably by 3 weeks, he essentially felt like he had a near normal knee. And that I can tell without an MRI scan. I can just I can tell probably he just had an ACL tear and did not tear any cartilage. My biggest concern is not always that the ACL is torn. There's a misconception that that's a crippling sort of thing, that you'll never walk again, much less play sports if you don't have an ACL, but that's not true. Plenty of people are out there with an ACL torn or deficient knee that are functioning and don't even know it. It's the fact that the instability that develops in active people can lead to cartilage tears, like Judith talked about, or meniscus tears. So a young athlete, it's been shown that if you have a 16 to 18-year-old that's participating in high-level sports, in high school, and they are participating with a torn ACL, they've got a 75% chance in 1 year's time of tearing their meniscus. And the meniscus is most related to those down the road who are going to develop arthritis, tears of the meniscus.
Yeah, so very quick, I'm sorry, go ahead.
I was going to say, so preventing cartilage injury and meniscus injuries is one of the reasons that we're doing ACL reconstruction. So I would say a young athlete who wants to maintain their sports is going to get offered ACL reconstruction surgery, both to stabilize their knee, but to also prevent secondary injury to the cartilage and meniscus down the road, because I think that's how you prevent arthritis going forward.
So allow it to stay stable so that the meniscus, the cartilage that kind of forms the smooth borders of the both joints.
Allows our joints to glide.
The cushions of the joint.
The cushions and the gliders.
You got to protect the cushions of the joint. Otherwise,
shock absorption.
Otherwise, there's a high correlation with arthritis.
Right. I had a buddy of mine played football all the way through college or high school. Senior year in high school, he was playing basketball, planted a foot, popped an ACL. Mm-hmm. So they took him to surgery, and they removed both of the meniscus. They just used to take the meniscus out. Apparently it was torn. And then I think that was it. They took the meniscus out and they didn't replace the ACL. I think they've done, and he's got a bad knee because of it now. As an older guy, arthritis, he's had it replaced.
The internal structures of the knee were totally changed.
Yeah. So, but then they went through a phase where they replaced that ACL with a carbon rope, and that failed, as I understand it. What are they doing now? They're dragging a ligament off from somewhere else, or what?
The two main types of soft tissue grafts are either using a portion of your hamstrings or the patellar tendon and with bone blocks on either side.
So you bring them in. I mean, it's a transplant.
Yep. Of your own tissue. You've got, and that's what's called autograft, using your own tissues. There's a big push lately in an increasing use of allograft tissue, which is somebody else's donor tendon, and that's getting in some places in the country use as high as 50 to 75% of all ACLs done with those tissues.
With donor tissue, and you don't need to do anti-transplant rejection.
No, it's biologically unrecognizable from your own tissue.
Okay. Yeah, Judith.
Well, I was going to say, doesn't even saying these sentences make you think how much nicer it would be not to have the surgery?
Yes, let's talk about prevention again, shall we? I am so glad that I didn't have that injury that my buddy had, because I am 62, still running.
And you're running. Well, what I was going to say is, the differences in the kinds of surgery are to me, I think, obviously this is very important, that the surgery be done competently, and the surgery is a good surgery, and it definitely helps a lot of people. But of course, we would always prefer that people prevent the injury. We say that the best thing is that you really don't need to see the sports medicine physician, but that you get to see the athletic field.
Yes, you get to see that athletic field.
That just seems much better to me.
I thought the important issue that I've learned in my life, and why I'm still running, is that I run with a bent knee. I come down on a bent knee. I look like I'm a squatty guy running like Groucho Marx or like a duck, but my knee stays functioning, and I don't seem to get into trouble. And I'm happy that it's still been working so far. So anything more about the ACL injury, and if I've destroyed those cushions, how do I replace them now?
Typically, there's some people doing some things with the transplantation of cartilage, transplantation of meniscus, cartilage and meniscus tissue, and I do some of that surgery. But again, I think that the main thing is trying to prevent those injuries from happening in the first place. Because most of the time when people get to me and they've had maybe a total meniscectomy 20 years ago, usually there's too much arthritis to do anything about other than arthritis treatments, be it operative or non-operative.
Okay.
Because I mean, if you want to restore the cushion, there are some simple things you could think of, though, to discuss with your doctor, such as getting artificial joint fluid injections, which can be helpful for some patients. Right. And it's still worth having a conversation to ask your doctor to see what might help.
All right, good. Well, one way to maybe avoid a sports-related injury is to avoid participating in sports. But what is the real trade-off we make if we don't take the chance and join the team? Sports and youth teach lessons for life. In our family, the kids took advantage of the great summer recreation programs, and then the school organized physical activity and sports. I know there are sports-related injuries that can happen, but on balance, the benefits are well worth the risk. As I see it, there are two major lessons resulting from all these childhood sports. First, sports can help us realize the value of teamwork. When we work together in collaboration and harmony, then not only do we accomplish more, but there becomes a sense of community that can become a template for the rest of our lives. This is an important lesson for not only the young people playing sports, but maybe a reminder for all the parents and fans up in the stands. When people realize the value of the cooperative spirit and the energy enhanced by working together, then we have families that raise happy, healthy kids. And we have communities that hum with synergy. Second lesson, sports can help us realize the value of physical conditioning. When we're young, we all seem to get some conditioning automatically, but as we play sports, after some aches and stiffness, muscles develop. Breathing becomes easy, and everything works like a well-oiled machine. At the end of a track season, the senior year in high school, I remember thinking my body was working so well I could run almost forever. It's that memory of optimal conditioning and the comfort and confidence that came with it which has driven me to exercise as an adult. After some aches and stiffness, it feels very good to be in shape. The experience of sports as a youth taught me the value of physical conditioning. Well, more than 38 million children and adolescents participate in organized sports in the U.S. each year. They learn teamwork as they bring their bodies into optimal conditioning. We should not forget the lessons we learn from sports. That guy just goes on and on and on. So, Erik, tell me what you would say if a parent says, can't we just give that guy a brace and put him back in the field? I mean, does he have to have that ACL repair? I think that a brace can help, but I wouldn't feel comfortable with a young athlete participating in contact sports with just a brace, because studies have shown that the braces do not prevent ACL tears. So I've got a 40, and then he became 50, and now he's 60-year-old a doctor who played racquetball, but I think he destroyed his knees on racquetball, and he wore a brace religiously. And finally it had to be replaced. Could he have done something different? Did he overdo it?
He probably had the anatomical setup, either an injury or an alignment problem, like we talked about with the car wheel and tire, that predisposed him to have the knee wear out, or it was just in his genes, and that's a frontier which we're just starting to learn things about. Some people, it's just in their cards.
Yeah, their cards.
And remember, though, weight loss, because joints are mechanical, in a sense that if we decrease stress on joints, this can help. And so weight loss is difficult, but can be helpful in the treatment of arthritis and in the treatment of many types of joint pain.
If we could do it, you know.
If we could only do it.
So tell us a little bit about 2020. We've got a little bit of time left.
Oh, absolutely. Vision 2020 is a national program that's trying to create equality for women across a broad range of different social issues, and each state has its own initiative. And in South Dakota specifically, the project is to decrease anterior cruciate ligament injuries of the knee in women. But actually, the good news is these prevention programs that we've discussed here will also help our male athletes, because, you know, obviously we want all our athletes to be as healthy as possible.
Yes, we do. Not just the girls, but the guys
everybody.
too.
We want it for everybody.
Wow, this is really great information, the non-related Petersons. Yeah. Thank you both so much for joining us.
Oh, thank you, Rick, so much for having me on the show, and wonderful to
it was my pleasure.
Have the discussion.
Good. A question to our loyal watchers. Have you been impacted by something you have seen on one of our shows? Have you sought medical care because something you have learned on our on-call show? We would love your feedback. Email us at tvtv@brookings.net. Thank you for watching. Until next time, stay healthy, people.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.